Welcome to AETCM, the emergency medicine channel. So, shall we start? A 60-year-old female, known case of type 2 diabetes, presents to the ER with headache and vomiting of 1-day duration. On our initial 10-second assessment, patient was conscious, oriented and obeying commands. Coming to primary survey, airway was patent.
So this patient goes to, after the triage, goes to which area?
Yellow. Sort criteria.
Sort criteria, everything came walking, right?
Yes, sir.
Came walking, vitals are all stable. Okay, so probably green area. Okay.
Coming to primary survey, airway was patent. Breathing wise, respiratory rate of 20 per minute, saturation of 98% in room air. Circulation, BP of 150/90 millimeters of mercury, pulse rate of 90 beats per minute. All peripheral pulses were equally palpable. Coming to disability, GCS of E4, V5 and M6, bilateral pupil equally reacting to light. The patient also has a pain score of 6/10, so at this point of time, injection PCM 1 gram IV stat was given. Coming to adjuncts of primary survey, we did a CBC CRP which showed a total count of 5000, CRP of 10, HB of 12.5. Coming to ample history, a 60-year-old female, known case of type 2 diabetes, presents to the ER with acute onset headache and associated with vomiting. She described the headache as bilateral headache and associated with neck pain and vomiting. Vomiting precedes the headache. There was also associated blurring of vision. Vomiting, there was 2 to 3 episodes and projectile in nature. No history of any fever, weakness, altered behavior. No history of any slurring of speech, deviation of angle of mouth, seizures or trauma. No history of similar illness in the past. The patient is currently on medication stab metformin 500 mg
Right now, this being a case of headache, first of all, you'll have to address the pain, make him comfortable, and then you'll have to apply the Socrates approach, because it's a case of pain, headache. So what are the DDs that you generally consider for any patient coming to the emergency department with headache?
One of the most common cause of headache is the tension headache and migraine. The other life-threatening causes are if there is any IC bleed, any meningitis can also cause headache.
Okay, so tension headache, migraine, cluster headache, trigeminal neuralgia,
Yes.
Temporal arteritis, giant arteritis, then pituitary apoplexy, IC bleed, SAH, ICH, meningitis, drug-induced headache. Okay, so these are the common things that we consider. So any headache, you'll have to go according with the Socrates approach. It's a case of pain. So the site, onset, character, radiation, associated symptoms, the timing of the pain, the exacerbating factor, relieving factor, and the severity, the pain score out of 10. All these things we'll have to take. Okay, so where this particular headache is, where this
Bilateral headaches are mostly in the occipital region.
occipital headache. Okay. Occipital headache can be a sudden onset. No?
Sudden onset
occipital headache can be a subarachnoid hemorrhage. Okay, then
associated with neck pain. And the patient describes
character,
headache
what is the character?
like throbbing headache.
Sudden onset throbbing headache on the occipital, bilateral, not on the front, on the back. Was it radiating to any?
It's not able to make it clear.
At times even sinusitis can also, like, that's also a cause of headache. But depending, because it's occipital headache, we are considering a subarachnoid hemorrhage. Okay. The character is throbbing. Okay. No radiation.
No radiation. He is complaining of neck pain. Not radiation as such, but neck pain is.
Neck pain. Okay. So neck pain, also neck stiffness, nuchal rigidity, nuchal stiffness, and all can be related to SAH. Okay. Then
Associated blurring of vision was also there, sir.
Okay. Blurring of vision. Which, like, both eyes or one eye or
He's saying like both eyes, sir.
both eyes? If it is a single eye and suppose it's an amaurosis fugax and all, it could be associated with the temporal arteritis and all. Okay. Even acute angle cluster glaucoma, that can also present with headache. Similar thing. Okay. Any so sight onset character radiation associated symptoms you have yet to timing. When did this happen?
Morning, sir. From morning onwards.
Morning suddenly.
Suddenly, sir.
Okay. And it has been gradually increasing or coming down or staying the same?
No, it is patient says that it is increasing, no decrease in the symptoms.
Increasing. Okay. Pain score is 4 by 10.
Say 6 by 10.
6 by 10. So gave PCM and he became comfortable.
No, sir. Initially we give PCM and we reassess, and still he is complaining of headache.
Okay. So you'll have to step up your analgesic thing. So associated symptoms?
Blurring of vision and vomiting.
So in this case, you'll have to, headache means you'll have to first address the 8 systems, right? So address the CNS. So what are the CNS complaints you'll ask for?
Any blurring of vision, any seizure.
Apart from headache, any seizure, any decreased
weakness,
level of consciousness, any
vomiting,
vision problem. That's all gastro complaints. Okay. So any vision problem, any
tinnitus,
any hearing problem, anything of that sort. Seizure, any seizure-like activity. All these things you'll have to ask. Then vision I've already told about. Then musculoskeletal, any weakness as such, any body pain, muscle pain, weakness, any girdle pain. Okay. So these things, girdle pain and all these can be associated with the arthritis, temporal arthritis. Okay. Then weakness, paralysis, no weakness as such.
No, sir, no weaknesses.
Okay. So CNS, musculoskeletal. Any swelling? Any swelling on
No,
any?
sir, no swelling.
No swelling. Okay. Any trauma? Any headache? Any trauma?
No trauma.
Recent trauma?
No trauma.
To the head, no trauma also. Okay. So it's not a traumatic issue. Then what about the serious thing? Any cardiac problems?
No chest pain, no palpitation, no.
Nothing
is
no palpitation, no chest pain, no dizziness, no shortness of breath, cough, wheezing, nothing is there. So serious RS, everything is clear. Okay. GIT?
No, vomiting was there, sir. Projectile vomiting.
Projectile vomiting.
Projectile vomiting. The vomiting precedes the headache and is not getting relieved even after vomiting.
Precedes the headache. Okay. So not getting relieved even after vomiting, what does it mean? Like,
not associated with any gastro. Probably CNS involvement.
At times migraine and all, it may relieve. So basically your DDs are, right now your primary, based on a history, it is primarily what? No genital urinary complaints, right? No genital urinary complaints. No lumps or bumps in the body, no oncological issues, no evening rise of temperature, nothing is there. No fever.
No fever.
No neck stiffness was there. No?
Neck stiffness.
Okay, so based on your HOPC, it fits mostly into a IC bleed or subarachnoid hemorrhage or okay, maybe cavernous sinus thrombosis. Okay, any like lacrimation, because in cluster headache and all, no, you'll get
autonomics,
like lacrimation and unilateral ptosis and even meiosis. That will be there in cluster headache. Migraine usually will have a aura. Okay. Probably our lead after vomiting, photophobia and all these things will be there in migraine. And what about the past history? Any relevant past history?
No, sir, no similar episodes in the past. Only on medications like tab, metformin, 500 mg twice daily.
Only diabetic.
Yes.
The female gender is itself is a this thing for SAH, predisposing factor for SAH. And also like any adult onset polycystic kidney disease or anything of that sort, nothing.
No symptoms, and they have not evaluated him.
Okay. No history of hypertension. Even smoking can be, even alcohol, smoking, all these can cause headache. This thing, SAH. Not on any drugs apart from
Apart from
metformin. Is he on any like cardiac sorbitrate or anything?
no.
Even sorbitrate can induce headache. NTG can induce headache. You'll have to be careful about all these things. Any surgeries, recent surgeries done?
No.
No surgery is done. Any scope is done. Any ultrasound scanning or anything done. Okay. Anything, any family history of any similar problems? The family history can be there, especially in aneurysm and all, no? Aneurysm rupture and all. Family history can be there. So nothing else.
Nothing else.
Okay. On examination?
On examination, sir, on CNS examination, GCS was E4 V5 M6, but when we checked the power, the right side power was like 4/5 on upper limb and lower limb, and on left side it was 5/5. Kernix was positive.
Right side 4/5.
Right side.
Right and upper limb as well as
Lower limb it was like 4/5.
So the problem is basically in the brain. Right? So other things are almost ruled out at the end of your examination. Okay. Then?
Pupil were bilaterally equally reacting to light, and reflexes were also preserved, sir. And neck stiffness we were able to demonstrate.
Pupils are equally reacting.
Equally reacting, sir.
Okay.
But neck stiffness we were able to elicit, sir. But no Budinsky sign, no Koenig sign. Neck stiffness was present, but other signs we were not able to elicit, sir.
Okay. Is he already having some cervical spondylosis or anything of that sort? Any underlying cervical?
No history. From history we haven't get anything.
Okay.
CVS was S1 S2 present, no murmurs. Respiratory system also normal, vesicular breath sounds, no added sounds. GIT was also soft, non-tendon bowel sounds present, sir. Then we again went to reassessment and the pain was still persisting. Then we have given injection tramadol.
We'll have to also ask apart from polycystic kidney disease, you'll have to ask about coarctation of aorta. That history has to be taken. Okay. You'll have to specifically ask. Generally, if you ask, like if you have got any problems, they may not come out with things. You'll have to specifically ask whether you have this thing. Okay.
Then since the pain persists, we have given injection tramadol 50 mg IV along with injection emisset, 4 mg.
Oh, okay. Why not NSAID like ketorolac or?
We haven't checked the creatinine also, so that's why. Yeah, tramadol was easily available for us. So
because tramadol itself will cause vomiting, right? So, because the patient doesn't come with a headache as well as vomiting. Tramadol itself is cause vomiting. So we probably given ondansetron before that.
The symptoms were still persisting, but due to the severity of the headache, like she was saying that it was worst headache and severe throbbing headache, and we are able to elicit right upper limb and right lower limb slight weakness also. So we immediately take a CT brain to rule out bleed. But CT showed subarachnoid hemorrhage involving the anterior cerebral area. So then we went ahead with MR angiogram that showed aneurysmal rupture of the anterior communicating artery.
So where all like it can happen, the thing SAH, right?
SAH.
So SAH, the cause of SAH is basically aneurysm rupture. Okay. So where all it can happen usually?
In the anterior communicating artery.
ACA can happen. This happened in the ACA.
ACS.
Then
Posterior communicating.
MC also you can do. And even PCA also can have a aneurysm. If it's associated with a is it any third nerve palsy or anything?
No,
nothing. Okay.
Okay.
Okay. So you'll have to, at times you may get questions in MCQs for your MR command or it is regarding Hunt and Hess classification of SAH as well as the WFNS classification of SAH. You'll have to note down what exact the points is and all. Okay. What classification? Patient has come with so and so complaints with so and so weakness. What could be the grading as per WFNS or Hunt and Hess? So that you'll have to find out. Okay. Then
we went ahead with the MR angiogram.
even patients with tumor and all also will have headaches. Pseudo tumor cerebri, all these things, a patient can have headache. So at this point of time, it's better to involve the neurosurgery straight away, right now itself. Okay. Was there any cerebral edema as such?
No, sir. No midline shift mass
cerebral
effect or
edema. Okay.
edema was
Pure SAH, diffuse SAH.
yes, sir. Localized to the anterior cerebral.
Okay.
So immediately we keep the patient in the head
MR
angiogram. That showed aneurysmal rupture of the anterior communicating arteries. Then we immediately advise the patient to head and elevation to 30 degree and avoid any necklines.
That is to decrease ICP. The measures with the non-medical measures to decrease ICP. Raising the head and to 30 degrees, avoiding the necklines. Okay. Then
Or neckties, anything.
or neckties should be avoided.
Then we have given injection MSET for ondansetron we have given since episodes of vomiting was there. And then to reduce the cerebral edema, everything we started the patient with 3% saline. And we were monitoring the BP, closely monitoring the BP, sir. Our target was to decrease.
Nimodipine has to be given, no? Nimodipine.
Non-traumatic cases, we have taken nimodipine.
Nimodipine. How much dose?
40 mg, 60 mg.
60 mg.
60 mg.
What is 60 mg IV? Every 4th hourly, no?
Yes.
For at least 21 days or so. Okay, then?
Then BP control has to be maintained. Vitals and GCS are closely monitored.
What was the BP?
On arrival it was 150/90, but when we reassessed the BP came like 190/100.
Okay, so what you give for the...
We have given injection labetalol 20 mg. We have given, sir. And our target was to decrease the systolic.
What is the complication of this thing? If you don't give nimodipine and all, nimodipine decreases the vasospasm. If vasospasm happens, it can even lead to ischemic stroke because of vasospasm. Okay, and it can aggravate the IC bleed as such. Okay, continue.
Then we have given injection labetalol 20 mg, and the BP came down to 160. Our target was to keep a systolic blood pressure less than 160 or a mean arterial pressure around 110. Sir.
Less than 160, 110.
110. And GCS was also closely monitored. If any fall in
GCS as well as the pupils should be closely monitored. And also the vital signs.
Vitals. Then we involved the neurosurgery team for further management.
Okay. Anything more to?
Since there was no uncal herniation or mass vector midline, should we have been given injection mannitol also. If any uncal herniation anything was there, we should have given mannitol also. And Foley's catheterization is needed and minimal ambulation should be maintained. If any fall in GCS is there by a drop of 2 or more than 2 points, then immediate repeat CT has to be taken after ruling out hypoglycemia.
All right.